Arrhythmias are among the most common disorders of the heart. In the United States, atrial fibrillation affects nearly 3 million patients. During the next hour, Marshfield Clinic electrophysiologists on staff at St. Joseph's Hospital in Marshfield, Wisconsin, will broadcast live over the internet a panel discussion and non-surgical catheter ablation procedure for the treatment of atrial fibrillation.
Ablation for atrial fibrillation is one of the latest and most promising techniques in the management of atrial fibrillation. It's a catheter-based procedure, the intent of which is ideally to cure patients with these common heart rhythm abnormalities.
The goal of the procedure is to completely eliminate atrial fibrillation and therefore eliminate the need for medication.
You, the viewer, can send in your questions to the surgeons during this webcast by clicking the M-Direct Access button on your screen.
Welcome to the first webcast from St. Joseph's Hospital and the Marshfield Clinic in Marshfield, Wisconsin. I am Humberto A. I'm the Director of Cardiac Electrophysiology at the Marshfield Clinic and St. Joseph's Hospital. I am joined today by Dr. John Hayes, Chair of the Department of Cardiology at both institutions, as well as for Dr. Param Sharma, Director of the Pacemaker Clinic at our institutions. Participating in the webcast later in the patient segment of the study will be Dr. Peter Smith, Director of the Heart Failure Clinic at St. Joseph's Hospital. Our topic today is catheter ablation for the treatment of atrial fibrillation. And we had discussed, we thought before we start with the procedure itself, we would give you an overview of the significance of atrial fibrillation in our country today. Atrial fibrillation, as this electrocardiogram shows, is a rapid heart rhythm of the upper chambers of the heart that is associated with an increased risk of stroke and death. There are symptoms such as shortness of breath, palpitations, and it can also be asymptomatic. The outline that we will follow today will be to cover the incidence, or how many new cases of atrial fibrillation there are, the prevalence, the morbidity associated with this condition, its mortality, treatment option, and then discuss some cases. First, let's talk about the incidence of atrial fibrillation. There have been 5 studies that have evaluated new-onset atrial fibrillation in the general population. We're all familiar with the Framingham Heart Study. There are other studies. One of those is the MESA study done right here in Marshfield. We're fortunate in Marshfield that in the red center of the slide that you can see, in the 14 zip codes that surround Marshfield, we essentially provide all of the care that is served to the residents, the 60,000 residents that live in this area. We capture virtually all deaths, hospital encounters, outpatient visits, etc. This database is updated daily and it provides for long-term follow-up. This has allowed to do the only evaluation of paroxysmal supraventricular tachycardia and atrial flutter. Others have done atrial fibrillation as well as us. And as you can see, per 100,000 persons per year, there are approximately 35 cases, new cases of paroxysmal supraventricular tachycardia, 82 cases of atrial flutter, and 240 cases of atrial fibrillation. So atrial fibrillation is far more common. As we can see from these projections, we estimate there are approximately 90,000 cases of paroxysmal supraventricular tachycardia, 200,000 new cases of atrial flutter, and a whole 500,000 patients with atrial fibrillation.
Arrhythmias most common and treated with radiofrequency ablation remain to be supraventricular tachycardias and atrial flutter. And although we see a lot more patients with atrial fibrillation, this technology is not used for these arrhythmias.
Not as much, that's right, but it's a very common occurrence. Thank you, Param. The incidence of atrial fibrillation, as this slide shows, increases substantially with advance in age, and it doubles per decade of life after the age of 50. This slide here demonstrates how the prevalence of atrial fibrillation also doubles per decade of life. And although it is more common in males than it is in females, since there are more female elderly patients, the overall number of patients with atrial fibrillation is about the same for males and females. Atrial fibrillation is being estimated there are approximately 2.5 to 3 million patients with atrial fibrillation, and the numbers are expected to increase to over 5 million by the year 2050.
Now, Umberto, I find this slide quite remarkable because it shows us that while atrial fibrillation is almost of epidemic proportions today, certainly in the near future, it threatens to overwhelm us with the number of patients who are going to be affected. And so while we're talking about an exciting procedure today to help many patients with atrial fibrillation, I think in the future we really need to focus more heavily on strategies to prevent atrial fibrillation if we're going to have an impact on such huge numbers of patients.
That's exactly right. Thank you, John, for those excellent comments. Atrial fibrillation, we know, is also associated with an increased risk of stroke. We've known that patients with rheumatic fever have several-fold increased risk of stroke, but then we learned in the late 1980s and 1990s that it's also associated with a 5-fold increase in the risk of stroke in patients that don't have rheumatic heart disease. We also know that the percent of strokes due to atrial fibrillation advances with age.
And strokes related to atrial fibrillation are more incapacitating and more likely to be fatal.
That's right. So not only is it very frequent, but they're far more devastating when strokes occur in atrial fibrillation. This slide simply demonstrates that atrial fibrillation doubles the risk of death. So after we adjust for all other conditions, age, sex, diabetes, hypertension, heart failure, atrial fibrillation remains an independent predictor of death, and the risk is twofold, as we have shown as recently as in the 1990s here in Marshfield. So we've summarized that atrial fibrillation, the incidence doubles per decade of life. The prevalence increases with age, and it also doubles with this advance in each decade of life, and is associated with a 5-fold increase of stroke and a twice increased risk of mortality. So studies have demonstrated that treating patients with warfarin atrial fibrillation lowers the risk of stroke. Our next challenge then was to see whether keeping patients in normal rhythm with antiarrhythmic drugs decrease the risk of death. And there are 5 such studies that I've listed here. I will focus on the AFFIRM study, which was the investigation in which we participated for a number of reasons. AFFIRM is by far the largest studies of the 5 research investigations that compare rate versus rhythm. And as you can see from this slide, AFFIRM alone accounts for nearly 79% of all patients in all trials. In addition, because the follow-up in AFFIRM was longer, if we look at the cumulative follow-up experience in AFFIRM, it was 3.5 years average follow-up experience, over 5,000 patients. So what we know about atrial fibrillation in terms of follow-up experience, nearly 90% of that is due to what we learned in AFFIRM. And we were very fortunate in Marshfield, as you guys know, that we were the largest of the participating centers in AFFIRM of all 213 centers in the U.S. and Canada. But what did we learn from AFFIRM? And I will summarize briefly some of the lessons from AFFIRM. First, we learned that we compare rate versus rhythm with the currently available antiarrhythmic drugs, that there was no survival benefit. The second issue was, did it lower the risk of stroke? We know that where there are patients with atrial fibrillation are treated with a strategy that controls rate, as opposed to one that emphasizes the maintenance of normal sinus rhythm with antiarrhythmic drugs, that the risk of stroke is the same, and these patients need to remain in anticoagulation. We've also done studies comparing functional capacity or quality of life, and in patients similar to those in AFFIRM, this functional capacity and quality of life was the same, whether the patients were in the rate control arm or the rhythm control arms. We then did an economic analysis, and even though we know that it doesn't lower mortality, doesn't lower the risk of stroke, that antiarrhythmic drugs do not improve quality of life or functional capacity, we know for sure that it is associated with a substantial increase in cost. Over the 3.5 years of study, it was over $5,000 greater per patient to keep them in sinus, treat them with the antiarrhythmic drugs. But just when we thought we had the answer to this big picture in the AFFIRM study, we learned that patients that could be maintained in normal rhythm without the use of antiarrhythmic drugs did better. And what that tells us is that currently available antiarrhythmic drugs are neither highly efficacious or highly safe, and maybe if we had better modalities that would improve this phenomenon, that we could improve outcomes in atrial fibrillation. Parm, I would like for you, if you would, we've discussed the epidemiology of atrial fibrillation, the morbidity and mortality, and some of the current treatments very rapidly, but I would like for you, if you would, summarize for us the current treatment of atrial fibrillation for the average patient, and if you would then tell us who would be the ideal candidate for a catheter ablation procedure.
Humberto, the goal of the treatment in patients with atrial fibrillation is to control the heart rate, prevent the thromboembolic complications, and maintain sinus rhythm. The control of heart rate is very important because patients are presenting with symptoms which are mainly related to rapid heart rhythm, shortness of breath, and congestive heart failure as a result of this extremely rapid ventricular response. Anticoagulation with Coumadin is important to maintain the INR between 2 and 3 to prevent risk of stroke and embolic phenomena to other parts of the body.
That's right.
Maintenance of sinus rhythm is important in patients who are symptomatic even after their rate is well controlled. And for this purpose, antiarrhythmic medications have been used for years. These medications can control arrhythmia in many patients but may not be successful in everybody. In those patients, newer technology has given us some answers. Radiofrequency ablation is one of such procedures. Atrial defibrillators, surgical procedures to maintain sinus rhythm have also been used. Today, we'll be learning more about the radiofrequency ablation procedure. The patients who have failed one or two antiarrhythmic medications and are still quite symptomatic with frequent episodes of atrial fibrillation may be considered for this form of therapy.
Thank you, Parham. That was an excellent summary of the current treatment of atrial fibrillation and the potential role of catheter ablation. John, would you tell us about the patient that we're about to see and tell us more details about that individual?
Sure. The patient who underwent the procedure that we're going to see is a patient I've followed for several years for atrial fibrillation. And he's a 60-year-old gentleman who's been otherwise healthy besides his atrial fibrillation. He's been active and has had a problem with increasing frequency of episodes of atrial fibrillation to the point that he's in atrial fibrillation on a daily basis. It is self-terminating but recurs quite frequently. Despite medication, he has continued to be short of breath, feel weak and tired, and have a sensation of palpitation. And
this is a terrible sensation.
Well, it's really limited his lifestyle. He's a very active individual. In fact, works part-time fighting fires in the mountains out west, and became very difficult for him to continue doing that with the recurrent fibrillation. So when this procedure became available, he was very interested in trying the procedure to see if he could get a better quality of life if we could eliminate his atrial fibrillation. So let's go ahead and go to the procedure and take a look.
So we're going to go to the lab now and proceed.
The patient is under conscious sedation with intravenous Versed and fentanyl, and we have three catheters in the three sheaths in the right femoral vein here. Two provide EP catheters into the right ventricle and coronary sinus. One has a sheath that is transeptally placed into the left atrium. We also have a sheath in the right femoral artery for blood pressure monitoring. At the left groin, we have a sheath with an intracardiac ultrasound catheter threaded through it, and that catheter is up in the right atrium. In the lab, we have multiple people involved in the procedure. At the head of the table is one of our EP lab nurses, Joe, who will be monitoring the patient and providing sedation throughout the procedure. Over at the foot of the bed, another EP lab nurse, Kelly, will be helping with the intracardiac ultrasound, as well as helping us move the fluoroscopy. Dr. Peter Smith, one of my partners and another electrophysiologist, is also with to assist with the mapping and ablation procedure today. And over way in the back here at the 3D mapping system is Cindy. A little hard to see her there in the back, and she's happy about that. So, if you look at the fluoroscopy screen, you can see that we have three catheters in the heart One of those at the lower aspect of the screen is in the coronary sinus and is used as an anatomic reference for our 3D mapping system. There's one catheter in the right ventricular apex, the one that's looped to the bottom left of the screen, and that provides backup ventricular pacing. Sometimes when ablating near the upper pulmonary veins, you have some reflex vagal slowing, and so it's important to have some backup pacing. The third catheter at the upper part of the screen is in the left atrial appendage right now through the transeptal sheath. In order to guide us through the anatomy, what we're going to do is use that ablation catheter to tag all of the pulmonary veins and then make a 3D map of our left atrium using the Endocardial Solutions Navix system. We're guided by CT images of the left atrium, which are over here out of view, but they help us define up front before the procedure the number of veins and the location of those veins with relation to each other. So the first step of the procedure is to put the catheter in all the pulmonary veins so that we can mark where they are on our 3D mapping system.
Yeah, I'll go back and sit down.
Okay. All right. If you want to go LEO with the fluoroscopy, please. Okay, so now we're trying to find the left superior pulmonary vein, and sometimes it's a little hard to find the orifice, but once we pop into the vein, sometimes it seems like we can't keep out of it. So here we're in the left superior pulmonary vein, and we're just going to pull the catheter back. And as we do that on our 3D mapping system, Dr. Smith is going to label the vein with these white balls here, which are just lesion markers to tell us where the vein is. Now the tip of the catheter has flipped down into the left inferior pulmonary vein, and I begin to pull back from there. Dr. Smith is watching very carefully to look at the size of the electrical signal to help tell when we're outside of the vein, because we want to be very careful to mark the origin of the vein with the atrium so that we know that when we start ablating, we're outside the vein. Now here we've rotated the catheter around to the right side of the left atrium, and we're looking for the right inferior and right superior pulmonary vein.
Thank you, John. That was a great summary. Parham, for the average patient that is having a catheter ablation procedure for atrial fibrillation, what can they expect? When do they get to the hospital? When do they go home? What happens in the early period? Could you summarize that for us? And then tell us a little bit about, again, the ideal candidate.
The patients come first to the clinic and discuss the procedure and complications with the physician, and on the day of the procedure, they come to the lab after being fasting for 8 hours or more, and then taken to the electrophysiology lab. There they are very comfortable. They are given sedation and local anesthetic as the procedure is started. The sheaths are placed and the procedure is done. Once the procedure is done, they go back to their room where they stay in bed for 4 to 6 hours, and after that they may be able to get up and start walking. By next day, most of the patients go home. The patients who are coming for this ablation procedure are usually patients who are highly symptomatic from atrial fibrillation, usually have failed multiple antiarrhythmic drugs, are younger than 70, although this may be decided on each individual patient.
Right.
And these patients should be able to take anticoagulation for 3 to 6 months after the procedure.
Great, that's a great summary. So patients come in as an outpatient, they go home the next day, most of them go home in normal rhythm. John, could we go back to the lab, and if you could tell us a little more about sort of where do we go from here?
Okay, well we've mapped the left pulmonary veins, and we moved over to identify the right pulmonary veins, and so we need to find them, and then we need to create a 3D representation of the left atrium. Let's go back to the lab and take a look. So here we're over toward the right side, and now we're sweeping the catheter around the atrium. And as we do this, the 3D mapping system is generating a 3D picture of the left atrium. This is done by having three sets of patches on the patient that generate an electrical signal that the catheter inside the heart can sense, and kind of like a local GPS. And by doing this, we can tell where the catheter is in space, and we can mark it, and this allows us to create the 3D anatomy. Now, this takes a lot of interaction between the person manipulating the catheter and the other physician or nurses who are also helping run the computer equipment. We want to be sure that we accurately represent the atrium, for example, by not collecting signals if we drop into the ventricle or out the pulmonary veins. So by swinging the catheter around through the atrium, you can see that we create a shell or 3D representation. Now, we also use ultrasound. This is a picture of the intracardiac ultrasound, and you can see the shadow of the catheter heading up to the left superior pulmonary vein in the lower right-hand corner of the picture. Again, the ultrasound is useful in telling us when we're near the origin of the vein so that we can stay outside the vein. Here you can see the catheter represented on the 3D mapping as the white moving cylinder with the green tip. And when we're pressing against the wall of the atrium, it'll provide a green surface marker or signal to know we're against the wall. This will allow us to be able to project our ablation lesions on the 3D anatomy.
So, John, we've done the anatomy of the heart. We've now know the areas that we need to stay from. Will you tell us why we need to stay away from the pulmonary veins and the kind of lesions that we deliver? How do we do that?
Well, what we're trying to do is isolate the pulmonary veins from the rest of the atrium so that triggers that are originating inside those pulmonary veins are not able to get out and spread to the rest of the atrium. Early attempts to do this by ablating inside the pulmonary veins resulted in narrowing or stenosis of those pulmonary veins. So we want to stay outside the veins and create a continuous circular lesion all the way around the veins to block them electrically from the rest of the atrium. And that's the what we call the wide area circumferential ablation portion of the procedure. By cauterizing around the around the orifices of the veins, we can do that. Now, in addition, we apply some linear lesions or linear scars in the atrium across the roof of the atrium and from the left pulmonary veins down to the mitral valve, as well as across the right atrial isthmus, in order to try to further block atrial flutters and other triggers that could occur from outside the pulmonary veins.
Okay, that's great. So what we're really trying to do is create compartments whereby it would preclude then continuous or electrical areas of continuous conduction between different segments.
That's correct. Because the atrial fibrillation can originate from multiple different areas in the atrium, we need to block off multiple areas from having access to the rest of the atria. Let's go ahead now and go back to the lab and see how we do that. We've created our 3D anatomy, and now we're simply going to use that to guide us to apply radiofrequency energy to heat up and cauterize or scar the tissue to block it. And on our 3D mapping system, we project that by placing the lesion markers, as you can see there in orange, when we've applied adequate radiofrequency energy to decrease the amplitude of the electrical signal in that area. And again, this takes a lot of interaction between those in the lab to determine that the catheter has been in a certain position long enough to adequately apply heat in that area. Now, sometimes it takes some very subtle catheter movements in order to move, because we're not always covering such great distances. And so by simply rotating the catheter, pushing or pulling on it, we manipulate it around the atria and apply the radiofrequency energy in order to create the scar. Now, the catheter, the tip of the catheter can also deflect. It has a little handle to allow the catheter tip to bend, and that gives us some further mobility to work our way around in the atrium. And that's what we're doing here. In the picture, you can see that, that we're slowly making our way around the left pulmonary veins, creating this linear scar. Again, just with some very subtle movements of the catheter. Now, there we just saw on the recording that atrial fibrillation just terminated back to normal rhythm. And that's a common occurrence during the procedure. We don't quit what we're doing right then and there, though. We continue to ablate and finish off the anatomic set of lesions that we intended to create. And so here we're still working our way around, trying to circle these the pulmonary veins completely. Now, once we've done that, we'll then bring the catheter down across the mitral valve and pull up from there and create the linear lesion from the valve up to the pulmonary veins. And that's where the catheter is positioned now midway between the mitral annulus and the pulmonary veins on the fluoroscopy there. And here we see I just dropped a lesion down toward the mitral annulus there. Sometimes the catheter is not going to stay stable there, and we have to manipulate quite a bit until we can get it to sit right where we want it to. We're also, during this time, continuously monitoring with intracardiac ultrasound to look for excessive heating, because that can be an indicator of either too deep a penetration of the energy, or even you can potentially perforate the heart muscle. And so if we see any evidence of overheating, we come off right away and we adjust down our power settings to try to lessen the likelihood of complications. And so here's an example of the ultrasound with the catheter against the wall of the atrium. And so we can also see where we are relative to those pulmonary veins, as well as watch for overheating. And so that's very helpful to try to minimize the risks of the procedure.
So really, by having a catheter that is deflectable and then having anatomical as well as intracardiac position of the catheter, we can ensure safe lesions in a organized fashion.
Yes.
I have a number of questions, and I would like to encourage the viewers to submit their questions. If we will try to answer as many as we can. If we cannot answer your questions on the air, if you will, we will respond to them directly to you. The first question, and I would like for either one of you to answer them, is, Parham, for example, is there a difference in the anticipated success rate between patients that have paroxysmal atrial fibrillation and chronic atrial fibrillation?
Humberto, the success rate in patients with paroxysmal atrial fibrillation is greater because in many of these patients, the arrhythmia originates in the pulmonary veins and there may be multiple foci. On the other hand, in chronic atrial fibrillation, patient may have been in this arrhythmia for longer periods of time, and the success rate may be a little bit lower.
So it is potential curative for both, but the success rate is greater in paroxysmal cases.
Yes.
That's right. John, the next question is, a patient has a successful catheter ablation for atrial fibrillation, but over the initial 3 to 6 months period, they have recurrences of atrial fibrillation. What does it mean? Could you comment on that initial 3 months period following the ablation?
Well, it was recognized very early on. In fact, even with the surgical maze procedure, which was really the pioneering procedure that led to these sorts of efforts, that patients can have recurrent arrhythmias for anywhere from generally 1 to 3 months after the procedure, but that eventually, as the scarring heals and the remodeling process of the atrium takes place, these arrhythmias seem to abate. And so it's understood that patients can have recurrence early on that will eventually settle down. For that reason, it's important that patients stay on anticoagulation therapy for several months after the procedure. And many patients also will stay on antiarrhythmic therapy to try to lessen some of those recurrences. Some patients can also get more organized rapid rhythms called atrial flutters. And it's been reported that some of them can occur up to 6 months after the procedure, but beyond 6 months, many of those will go away as well. So when patients do have recurrence after the procedure, a lot of times it's a matter of sitting tight and waiting to see the full effects of the procedure with further time and healing.
So for the first few months, 3 months, you can expect recurrences. After that, if it recurs, then it's more likely that it wasn't totally successful without antiarrhythmic drugs.
Some patients are just not going to be able to be successfully ablated by these methods at this point in time. However, a certain percent of patients who were previously unable to be controlled with their antiarrhythmic therapy may now become controlled with the antiarrhythmic therapy. So even patients who have not had a full-blown cure, so to speak, from the procedure may benefit and may have better control of their rhythm after the procedure.
Because they could not be controlled with heart rhythm medicines, and now they can.
These are patients who were failing heart rhythm medicine previously, may now be controlled with heart rhythm medication. Hopefully, the majority of patients won't need that drug therapy, but if they do have recurrence, that's an option. Certainly, a certain percent of patients are going to consider having a second attempt at the procedure, and that's a possibility as well.
Well, and there was an article presented, an abstract presented at the American College of Cardiology last month, where patients that were treated with catheter ablation and antiarrhythmic drugs did better than those who were randomized only to antiarrhythmic drugs in terms of maintenance of sinus rhythm. So we're beginning to see randomized controlled trials into this catheter ablation.
That's right. I think what we've known is that the procedure certainly symptomatically benefits patients who had refractory arrhythmias. I think the data that we're waiting for is does this translate into long-term benefits as far as heart failure, as far as stroke, as far as mortality. And there has been some early indication that perhaps congestive heart failure is improved in those with weakening of the heart muscle if they also have atrial fibrillation and undergo this procedure. So I think we're starting to see some real outcome data come about, but it's early yet.
Since we don't have the long-term outcome of these patients, that's the reason that we are recommending this procedure for patients who are highly symptomatic. Once we have the data on the long-term outcome, this may move more towards the first-line therapy that may take a number of years.
Actually, Param, that was one of the questions. The question was, if the procedure is so great, is it first-line treatment in patients with atrial fibrillation?
Right.
Are the goals to control symptoms or cure, etc.?
Right. The answer is no at this point because we don't know the long-term outcome of these patients. There may be certain risks involved with this procedure which requires a transseptal puncture and radiofrequency ablation around the pulmonary veins, and we need more data to know that what the long-term outcome is going to be.
Right. Param, there's another question here that I think is interesting. It says, does a successful catheter ablation eliminate the need for anticoagulation immediately following the procedure?
The answer to that is these patients are still at risk of thromboembolic events, and there may also be possibility that the arrhythmia may come back till the scar lines are mature, and they may have arrhythmias for 3 to 6 months after the procedure. So
what John was saying earlier, right?
So the common practice is to continue anticoagulation.
Till we're sure that they're free of their recurrent arrhythmias. Absolutely.
John, here's another question. I think it's a related question. Everybody wants to know if this is a wonderful and potentially curative procedure, who are the people that should be considering? And one of the questions is, for symptomatic patients with atrial fibrillation, is catheter ablation recommended for most symptomatic patients with atrial fibrillation?
Well, I think we're still not at the point to say that most patients with atrial fibrillation are going to require this procedure. Many patients can still be controlled with medication. Many patients who have atrial fibrillation are minimally symptomatic or not symptomatic at all. So I would say at this point in time, it's really just the patients who are not doing well on medication who we consider. But at some point in the future, I think this is a very evolving situation, and I think that the indications for the procedure are likely to change.
Thank you, John. There's a lot of great questions. Let's go back to the lab, though. Could you walk us through the next phase of the patient segment?
We finished ablating around the left pulmonary veins, and now we have to work across the roof of the atrium and over to the right pulmonary veins. So let's go back to the lab and see how we do that. So here we are again, manipulating the catheter again by rotating the catheter at the groin site, watching the tip both on X-ray and with our 3D mapping system. And the nice thing about the 3D mapping system is that by simply moving it around on the screen, we can get a good idea where the catheter is without having to use the X-ray exposure and without having to move the X-ray camera or use multiple X-ray cameras. Again, it's sometimes fairly fine movements that are going to get us around in the atrium. But here we can see that we've tipped the pulmonary veins down to the lower right-hand corner of the screen. The right pulmonary veins are in the upper part of the screen, and we're going to work our way across the roof of the atrium up toward the right pulmonary veins. And you see where the arrow is sliding along between the left and right pulmonary veins. On fluoroscopy, this looks like what's shown here, where we have the catheter toward the left side of the atrium and we're sweeping it across the roof over to the right side. Again, ultrasound is very helpful to us to see where we're at relative to those pulmonary veins. This shows again the catheter across the septum into the left atrium. Here we can see that we're marking again the ablation lesions as we work our way across the roof. Now we have to be careful on the roof of the atrium because it's probably the thinnest part of the atrium going up over toward the right superior pulmonary vein. And so we try to sweep the catheter gently. We try not to embed it against the wall of the atrium, and that way lessen the risk of a puncture or perforation. Once again, we're monitoring constantly with ultrasound to look for evidence of overheating. We generally apply energy at about 50 watts, a temperature about 55 degrees Celsius, and previous use of higher energy did seem to be associated with a higher risk of perforations. Here we can see on the ultrasound that we're sweeping over toward the right pulmonary veins. You can see artifact from the catheter there. The right superior pulmonary vein is toward the lower right-hand corner of the screen. The left or the right inferior pulmonary vein going off toward about the 7 or 8 o'clock part of the picture. And again, we want to make sure we don't actually go into the right superior pulmonary vein. You can see here on our 3D mapping, we're pointing right up close to the right superior pulmonary vein, but not quite in it. And now we're going to start heading down the right side of the left atrium to encircle the right pulmonary veins here.
That's wonderful, John. That's a phenomenal review. There's a number of questions from viewers, and one of them is, it must be a surgeon, because the question is, how do you determine endpoints? When do you decide to quit in any given segment? Then the other two questions is, would you please discuss acute and chronic success rates for catheter ablation for atrial fibrillation?
Sure. Our endpoint of the procedure is to apply the lesions that we set out to do, the circular lesions and the linear lesions, irrespective of whether atrial fibrillation terminates while we're doing the procedure, because we know that that even if we're able to stop atrial fibrillation at the present time, there may be another trigger that's just not active today that at some other point in time may become active. So we apply a pretty well-defined set of lesions, and not everyone goes back to normal rhythm by the time we're finished with those lesions. Some patients do have to be cardioverted back to normal rhythm after the procedure, but again, that doesn't mean the long term they're not going to have success. Part of the difficulty has been defining at this point what is an adequate endpoint for the procedure. Some have suggested that the veins need to be totally isolated. Others have suggested you need to completely eliminate the ability to induce fibrillation, and that's somewhat controversial. We try to assure that the lesions are fairly complete and that there's very little, if any, electrical activity within the circles, and that the lines are rather complete across the areas that we're applying them. As far as short-term success rate, essentially everyone leaves the lab in normal rhythm, but again, for up to 3 months after the procedure, we can expect some recurrence. Long-term success rates have been in the literature anywhere between 60 and 80% success rate, depending on the population you're talking about, depending on whether or not they're controlled with antiarrhythmic therapy or not. And again, it seems that the chronic fibrillation patients have a lower success rate than the paroxysmal fibrillation patients, so they're toward the lower end of that range, whereas the paroxysmals are toward the higher end of that range. Again, it's difficult to compare because there are subtleties of different methods in each report, and different patient populations. But I think that comparatively speaking, the results are certainly superior to what antiarrhythmic therapy has been able to achieve.
Two questions. There's several more questions, but one I would make is, what, if any, is the role of catheter ablations in patients that have no symptoms, asymptomatic atrial fibrillation? And then the other one is, how does this procedure compare to surgical, heart surgical procedures for atrial fibrillation? Param, will you talk maybe about the role, if any, in patients that have asymptomatic atrial fibrillation? And then one of the two of you would talk, how does it compare to the MACE procedure, the mini MACE, the micro MACE, the mini ME, all of these other procedures that we hear so much about?
Humberto, at this time we are recommending this procedure in patients who are highly symptomatic from atrial fibrillation. The reasons are that we still don't know the long-term outcome of these patients, and the patients who are maintained with rate control medications and anticoagulation, a firm study has shown us that their outcome is equal to the patients who are maintained into sinus rhythm with antiarrhythmic drugs. We don't know whether the catheter ablation is going to be superior to antiarrhythmic drugs in terms of long-term maintenance of sinus rhythm. Till that data becomes available, it's a practice these days that the procedure is recommended in patients who are highly symptomatic.
Okay. John, would you comment about the other non-pharmacologic therapies? There's many of them, the experience, the success, what it involves, etc.
Well, again,
in an hour or less.
The foundation of the ablation procedure we're doing really started with the surgical MACE procedure, which is a rather extensive open heart surgical procedure, and for that reason didn't really catch on as a widespread therapy. That has seen resurgence lately because some of the technologies enable the surgeon to perform that easier than it was previously. So at this point in time, as far as an open heart surgical procedure, that's really reserved for patients who have fibrillation, who are having open heart surgery for other reasons, such as bypass surgery or valve replacement.
And in those individuals, it could be a big improvement.
Oh, that's right. And the surgical MACE procedure had a very high likelihood of being able to maintain normal rhythm in patients who had substantial heart disease, because those were essentially the patients undergoing that procedure. Now, there are some newer procedures that involve mini thoracotomy or thoracotomy by scope to apply radiofrequency energy similar to what we're doing, but from the outside of the heart. That doesn't involve placing catheters through the chest wall. We don't really know yet the role of this procedure, the long-term benefits. The data is relatively scant at this point in time, but there's certainly a potential for that procedure to also benefit patients. We just have to get a little more data yet before we know.
And I think it's fair to say that as promising as those procedures are, the number of surgical procedures that have been done are several-fold less than catheter ablation procedures for atrial fibrillation.
Well, despite the relatively new nature of this procedure,
of the catheter
ablation procedure, there actually have been reports in upwards of 8,000 patients. One center alone has reported their success or their results with over 6,000 patients for the procedure. So
that's a center in Italy, I believe.
That's correct. Yeah. So I think that you're right that there's actually a fair amount of experience with this with the catheter ablation procedure at this point. All being relatively new, though, we don't have real long-term. We have a couple years follow-up. We don't have much further out than that.
Okay. John, could we go back to the patient segment and then talk about what's the next phase in the procedure itself?
Okay, so when we were last at the procedure, we were isolating the right pulmonary veins. Once we've completed that and we're sure that all those lesions are adequately applied, we then move back over to the right atrium, and now we're going to want to ablate for right atrial flutter. So let's go back to the lab and look at this last segment.
Okay.
So now we're threading up a different catheter with a little larger ablation tip to the right atrium.
This is up the inferior vena cava?
We just thread up through the inferior vena cava. We've taken out the sheath that goes to the left atrium. And now what I'm doing is placing the catheter across the tricuspid valve into the ventricle so that I can pull it across so that we can ablate the rim of tissue between the tricuspid valve and the inferior vena cava. And this will block right atrial flutter. You can see on our 3D mapping system, my catheter tip is moving outside of the left atrial geometry because we're over on the right side. Now, to do the flutter ablation, we don't really need to create a 3D anatomy of the right atrium because it's a relatively straightforward linear application here. And so we're just going to use the 3D mapping system, though, to apply and mark our lesions to make sure that we got a fairly continuous line of radiofrequency across there. And so we get in the right position, and then we're going to apply the radiofrequency energy. Now, the isthmus is a little bit thicker than most of the left atrial tissue, and so generally we use a larger tip electrode that we can go up to 60 watts or even higher and up to 60 degrees because of the flow there tending to cool the catheter tip a little more. Now you can see on the 3D mapping system we use some yellow lesion markers to mark where we're ablating across the isthmus here.
Of the right atrium. We're now ablating in there.
Yes, right, we're now over on the right side. We try to go across the mid-isthmus because that limits the thickness or width of the isthmus there as opposed to being more medial or lateral where the isthmus is a little wider. Once we've applied energy adequately across and it looks like we've decreased the amplitude of electrograms all across the isthmus, we can actually test for block in the conduction across the isthmus by pacing either medial or lateral to the isthmus and measuring the amount of time it takes to travel around the atrium to get to the other side. That way we know that we've adequately blocked the isthmus there. Now we can also use our ultrasound here showing the catheter going across the tricuspid valve so that we can make sure we're in the right spot, particularly to make sure that we get adequately low enough to the junction between the inferior vena cava and right atrium. We know that a fair number of recurrences of atrial flutter after flutter ablation can be because of gaps that are left down at the inferior vena cava. We want to be careful at that area because, again, the atrium thins there and can be more prone to perforations or punctures.
Of course, we have a lot more experience with atrial flutter ablations. We've been doing those for many, many years, and the success rate is very high.
Oh, that's right. Atrial flutter was probably the first arrhythmia that we approached by making a long linear lesion. Up until that point, PSVT ablation really involved a rather pinpoint single focus of ablation. Once we realized that a linear lesion across the isthmus could interrupt right atrial flutter, that became a very promising and very viable treatment for atrial flutter. Really, the main limitation is that, unfortunately, probably the majority of patients who suffer from atrial flutter also have atrial fibrillation. And so while you may eliminate their atrial flutter, many of them go on to have atrial fibrillation. In fact, some of our patients who have undergone the fibrillation ablation procedure have previously had flutter ablation procedures. So now we have the methods, obviously, to approach both of those rhythms. Here, again, we're still across the mid-isthmus here, trying to assure that we got a continuous line. Again, we'll pace on each side of it. And then once we're done with that, we'll use the ultrasound to go back and look at our pulmonary veins on the left side to make sure we haven't caused any stenosis. And so we measure the flow in those veins just to be sure.
That's wonderful.
At that point, we're done with the procedure.
That's great. So there's one of the questions, Parham, if you would address them, is what are the potential complications of this procedure?
The potential complications with this procedure are the usual complications with any catheter-based procedure, including risk of hematoma formation, bleeding, infection, cardiac tamponade if there is a perforation and blood leaks out around the heart, and risk of stroke. Some patients may develop pulmonary vein stenosis, which may lead to symptoms in future.
That's right. So it is a procedure that is highly effective in selected patients, but it certainly has its potential risks, and we want to identify individuals that can benefit the most, and those are patients that are very symptomatic, that have failed antiarrhythmic drugs. We have a number of cases that we'd like to discuss if you guys would like to proceed. The first one, and these are patients that cases that have been based on individuals that we've been called by physicians and asked to comment. The first one is a 53-year-old female that has weekly episodes of atrial fibrillation lasting up to 48 hours. This, despite the fact that the rate of her atrial fibrillation is well controlled, she remains markedly dyspneic, has fatigue during those episodes. She has failed different antiarrhythmic drugs, including flecainide, sotalol, and dofetilide. She also has a history of hypertension. How would you manage that patient?
Well, I think this is a typical patient that we would see for consideration of catheter ablation. The patient is definitely symptomatic of the fibrillation. They've failed multiple antiarrhythmic agents, and so I think has a high probability of benefiting from the procedure. You could consider amiodarone therapy in this patient, but amiodarone has its own potential risks and complications that leads us to reserve the drug more often for patients with significant heart disease where there really may not be other good options.
That's right. Thank you. Partner, if you would do the next case, that's a 78-year-old man with intermittent atrial fibrillation lasting up to 24 hours. During the episodes of atrial fibrillation, their heart rate is between 100 and 130 beats per minute, and he feels palpitations and more shortness of breath. When not in atrial fibrillation, patient is still very fatigued. The resting heart rate is 43 beats per minute. He has severe chronic obstructive lung disease, and the current treatment is metoprolol, diltiazem, and digoxin. How would you manage such a patient? Is this someone that is a candidate for atrial fibrillation ablation, for example?
Humberto, this patient has both. At times he's very slow heart rhythms, and he's on medications which cause bradycardia, and when he goes back into atrial fibrillation, he's highly symptomatic. With his COPD and reactive airway disease, it may be difficult to increase the dose of certain medications like beta blockers, and such a patient may be better served by a procedure where we ablate the AV node.
So this will be an ablation of the conduction system, not the fibrillation itself.
Right, and then implant a permanent pacemaker, and this technology has shown that the majority of the patients do much better symptomatically. Although these patients do not require antiarrhythmic medications or rate control medications, they do require chronic anticoagulation.
And the advantage of this treatment in this patient would be that we can then stop the metoprolol, stop the diltiazem, stop the digoxin if that was the only indication. And oftentimes the medications alone have side effects that have that can exacerbate symptoms.
Right, and then this procedure being used for a number of years, we know the outcomes with this procedure, and if we try to ablate the atrial fibrillation, there may be other concerns with his age and risks of future complications.
Right. Plus the fact that looks like the heart rate is very slow when he's not in fibrillation. So
right, he would require a permanent pacemaker
right,
if he is on medications.
The next case is that of a 42-year-old man with episodes of atrial fibrillation approximately every 6 months. So the episodes last 10 to 20 minutes and are well tolerated. He has no underlying heart disease and he's on no medication. I think it's safe to say, if I may comment on this one, is that here's a patient that has what we would call lone atrial fibrillation. It's an individual in whom he has reasonably rare, tolerated symptoms for a short period of time. This patient is not at risk of stroke. It is hard to justify daily treatment with medications for something that occurs only every 6 months. They do not require anticoagulation therapy. I think it's fair to say that none of us would do a catheter ablation today.
That's right. I think it would be premature to consider a patient like this for ablation. While the younger someone is, the more anxious we are to be able to eliminate a condition, to free them up of that condition. But keeping in mind the potential risks of the procedure, we have to be cautious. And I think that until it's been shown to be superior to expectant waiting, I think it's probably better off that at some point he may well come to need the procedure, but at this point in time, probably not. And as you say, I don't think at this point he necessarily needs any medication.
That's a very good point, John. Is that what we're recommending today? This is April 5th, 2005, and the indication as well as the benefits and risks for the procedure is something that will continue to evolve. So for those that say watch the broadcast in several months, the broadcast will be available for a year after this recording. It may well be that the indications will evolve over time.
That's right. And the other thing is that the natural history of fibrillation is quite variable. He could go many, many years before his fibrillation worsens, whereas someone else, maybe they start out this way, but a year from now, their fibrillation has changed and become more frequent, more prolonged. Well, at that point, then, you may need to reconsider. So that's the other thing, is that when you make a decision how you're going to treat the fibrillation, that decision may change as the condition itself changes.
Here's another question, Parham. He's a 65-year-old man with chronic atrial fibrillation for the last 6 years. He has no symptoms on atenolol and warfarin, would like to get off medication. So here's a patient that has no symptoms but is on warfarin and atenolol, has a history of hypertension that is well controlled on the atenolol. Is this patient a candidate? I had someone almost identical to this that was sent to me for evaluation of possible catheter ablation.
Humberto, I would not recommend radiofrequency ablation to terminate atrial fibrillation for this patient. As we discussed during the presentation, that we don't know the long-term outcome related to these procedures, and it would be premature to treat these patients with radiofrequency ablation at this time.
Thank you. John, one of the questions is there a difference, and what are the different energy sources that are used in catheter ablation? Radiofrequency, microwaves, cryoablation. Will you talk about the different deliveries, energy sources?
Well, the main delivery system, certainly for atrial fibrillation ablation, has been radiofrequency energy. So a high-frequency radio wave which heats up the tip of the catheter and causes scarring that way. Now, for some arrhythmias, we do use cryoablation, where we actually freeze the tip of the catheter and cause scarring through freezing. The problem is that the cryoablation causes a much more limited area of scarring. The catheter is a little bit bulkier and harder to manipulate, and so is not yet suitable for a more extensive ablation such as atrial fibrillation. Ultrasound has also been tried. High-frequency ultrasound can heat up tissue and cause scarring as well, but has not yet been found to be suitable for ablating, particularly for atrial fibrillation. There is some exciting development in the area of cryo where you could simultaneously freeze the whole circumference of a pulmonary vein, and that shows some promise, but again is still experimental. So for the most part, radiofrequency energy is what's being used for atrial fibrillation.
Oh, thank you, John. I have a comment here from my daughter Kelsey, who is in Madrid, Spain, just telling us that she's watching us from there. I thought that was an interesting comment all the way. It must be very late in Madrid right now. Parham, there's a question here is, what are the restrictions that a patient would have immediately following the procedure? Talking about upon discharge from the hospital and for how long, as compared to surgery and other procedures?
Sure. Most patients are walking by the end of the day. By next day, they are able to go home. But we recommend not to lift anything heavy to avoid any bleeding complications from the groin.
Okay. Thank you. Another question, John, is, and there's a lot of questions coming in now, is possible complications of radiation just by the fluoroscopy of the procedure.
Yeah, that's a good question. We're always concerned about the use of X-ray energy for diagnostic or therapeutic type procedures. And we think that, particularly with the use of the 3D mapping system, we can limit the fluoroscopy exposure. We use a fluoroscopy that's called pulsed fluoroscopy, so it's not a continuous fluoroscopy. But in the early days of radiofrequency ablation, there was concern that such radiation exposure could lead in the long term to malignancies, and some studies and calculations were done and found that that the your lifetime risk of malignancy is so high that the added risk of radiation from a procedure like this is really quite minimal. Now, that's not to say that we don't take great pains to try to avoid or try to limit the amount of radiation that we expose the patient to, so that we do try to limit that.
Well, thank you, gentlemen. I think we have discussed the current treatment of atrial fibrillation. We've discussed how frequent the condition is, what are its associated risks, as well as in some detail the benefits, indications, and possible complications of this promising technology. I think we're coming to a closing. I would like to thank St. Joseph's Hospital and the Marshfield Clinic in Marshfield, Wisconsin, for helping us sponsor this discussion today. I would like to thank the panelists, Dr. Smith, who helped us with the procedure, Dr. Param Sharma, and Dr. John Hayes. I would like to remind everyone that the archived form of this transmission is available on the web for a year at the same website, and that we promise that we will answer all the emails that are submitted. Lastly, I'd like to remind physicians that continuing medical education credits are available for your participation in this trial, and then submitting questions answered appropriately. Thank you, gentlemen.
Thank you, Bert.
This has been a live webcast panel discussion of a non-surgical procedure for the treatment of atrial fibrillation with Marshfield Clinic electrophysiologists on staff at St. Joseph's Hospital in Marshfield, Wisconsin. For more information, to make a referral or make an appointment, click the buttons below.